Like I said, my name is James. This topic will be about moving beyond standard FDG imaging. We'll go into a little bit of background. I would like to talk about FDG imaging as a diagnostic tool. That will be the main topic of this discussion, moving away from cancer. Talk a little bit about equipment, and then just show a few examples. So just some background. FDG started in 1968, so this is not a new material. Dr. Josef Pakat, Department of Organic Chemistry in Charles University in Czechoslovakia, was the first to develop FDG. Later in the 70s, Brookhaven National Lab in the United States started to move it forward and administered it to the first human volunteers. So FDG is a glucose analog taken up by high glucose using cells, the brain, kidney, and cancer cells, where phosphorylation prevents the glucose from being released again from the cell once it has been reabsorbed. That is the key to FDG imaging. It gets trapped once it's phosphorylated into the cell and it cannot come back out. The normal, thus in common in the sister molecule, FDG cannot be, like I said, further metabolized. So typically FDG is used in cancer imaging, treatment monitoring, treatment planning, and restaging, and that's not what this short discussion is about. The purpose of this discussion is to go a little beyond standard oncologic imaging and to review FDG's other uses. I am not going to talk about infection uses. We have a full lecture on that tomorrow, which I'll go into. So lung cancer is the first thing. I'd like to talk about FDG as use in SPN, single pulmonary nodules. Lung cancer is a very serious condition. Overall, 15% of people in the United States diagnosed with lung cancer survive 5 years after diagnosis. It is a very debilitating disease, so therefore we need to be aggressive. Developing a comprehensive plan should include PET-CT. Biopsy surgery has significant risk, and they're not always diagnostic. Often you have to go back for more procedures. We need to utilize aggressive risk stratification in patients with single pulmonary nodules that are suspicious. We'd use a plan of CT screening and PET-CT at my institution. The CT screening program to evaluate patients with significant risk. For example, that is a 30-pack year history, older than 50, or family history of lung cancer. CT screening should be done on PET-CT, or can be done on PET-CT also, the very low-dose exam. As you can see, this graph is a very simple, but this is US data, just to make sure I'm clear. The most common cause of lung cancer is long-term exposure to tobacco smoke. I don't think anybody would, not understand that, which causes 80 to 90% of lung cancers. The graph simply shows the more you smoke, the more likely you are to get lung cancer. So who we're doing the CT screenings on are current or former smokers with a 30-pack year history that are aged 55 to 74. These people are at significant risk to develop lung cancer. Recent research from the National Cancer Institute lung cancer screening found that low-dose CT scan reduces death by 20% compared with chest x-ray. Chest x-rays can only find a lesion that is 2 centimeters or larger. That is a problem. We want to find much smaller lesions in order to fix lung cancer. The only way to survive lung cancer is to get it out early. That is the absolute best way to save someone's life. So how does PET-CT fit in? Using delay imaging can help our diagnostic accuracy of the exam. Delay imaging, the whole point of PET-CT is to understand the disease process. We need to understand how FDG gets into cells, how quickly it gets into cells, and in order to do that, we need to understand the model of when and how and where to image. Our goal is to aid the detection of cancer and to provide the safest place to biopsy. We always need to remember in doing single pulmonary nodule workups, single pulmonary nodule can just be a metastasis. It can be a colon cancer. It can be a prostate cancer or an ovarian cancer. It can be something that has spread to the lung. So we don't want to get blinders on and miss a larger disease process. So I'll show you an example from my institution. The patient presents with a lung abnormality on a screening CT. So our protocol, the way that we do this, patient is fasting, except for water 6 hours before the test. We check the patient's blood sugar. Our normal range is 80 to 120 is what we allow. Other than that, we will consult the physician for advice on how he or she would like to proceed. In our institution, it's very important to make sure that the patient is warm. That doesn't matter if it's winter, summer. If it's summer, the air conditioning's on. If it's winter, it's cold outside. You get a lot of brown fat uptake along the spine in lung cancer patients. Brown fat can be anywhere. It can actually be along the front of the lungs as well. Keeping the patient warm is very important. We use an IV on everybody. They're hydrated. We give the patients a diluted contrast. We don't use barium. We use an unflavored contrast for our patients' comfort. We inject 15 millicuries. Sorry, we don't use Becquerel, so it's normally a larger dose than most people use for PET scans. And then we allow them to rest quietly for 60 minutes. We image top of head to knees. I was very happy to hear that you guys do whole body imaging on most patients. That is excellent. I can tell you this is my 6th country of doing talks like this in the last year. Very few people do that. That is a great way to start. You're getting a whole picture of the body. It's really nice to be able to have the time to do that. Place back in the recliner, and then we wait 60 more minutes. We allow the patient to get back and rest further. And then we image just the chest. Now, you have to be careful here because you have to do the same parameters. If you do 3 minutes per bed position on the first image, you then have to do 3 minutes per bed position on the next image. You cannot change that. You also cannot change the CT slice thickness. If you do that, there is a partial volume defect. And understanding how our scanners work, for example, if you do a 5 millimeter cut through the chest initially and then go do a 2.5 millimeter, well, your SUV doubles. And that is a simple partial volume defect. And you can fool yourself into not understanding what's going on. We have to make sure we keep our protocols and parameters the same, and that should be the same from institution to institution. Anything that you do will change the standard uptake value. So this is kind of hard to see. If the pointer. Okay, we don't have a mouse. I'll try to use a finger. Oh, maybe not. That's okay. Well, basically what you have, the top scan, I just kind of cut off. It was a whole body scan, but you can see the SUV on there is 6.73 was the first SUV. And the second one, it goes up by 25%. Well, cancer will get more metabolically active with time. Infections such as pneumonia. Oh, here are the two. This one is 6.73, this one is 8.5, but 25% increase. Now that, for our physicians, that means that this is very likely a cancer. It's not pneumonia, it's not sarcoid, it's not something else in the disease process. And when you do this, we found that we went back and looked at 2,000 patients that had single pulmonary nodules. If you only look at this number here, you're about 92% accurate. If you take both into account, you get to 98% accurate. So 6% is, it doesn't sound like a whole lot, but when you take 2,000 patients, well, you've just changed the surgery and biopsies on over 100 patients. So it's significant. And, this doesn't cost any more to do this. This allows us to do the absolute best patient care. And, people die from biopsies. People die from surgery. So this helps us to be the absolute best that we can. And you can find this. You can do this in any kind of solid organ tumor. You can do this in the liver. You can do this in anything that the physician or you suspects that this may not be a cancer. It may be some sort of infectious process. You can do this type of imaging. So, as I said, it was a 23% increase in activity. Typically, our infections can even go down. And, until the physicians got used to what they were seeing here, they would still biopsy these types of things. And we would find that often it's a rounded pneumonia or it's something else other than cancer. So the hypothesis, and this has been studied for the last 2 decades, a lot of other countries are doing something similar, is cancer becomes more metabolically active with time. And it's simply the activity curve. It continues to rise. That's why we image at 45 to 60 minutes, because there's a quick peak in the blood pooling and it settles into the cells and then it starts to taper off. It's not quite a plateau. That's why we need to be very careful when we start our imaging. We need to be consistent. In the United States, our accrediting bodies say you need to start at 60 minutes. Well, that's very difficult when you have, typically some of our PET scanners in the departments I manage can do 30 patients a day. Well, it's easy to get behind if you have, older gentlemen that's slower to get off the camera, or, it's just, as you know, technologists, getting on and off the camera can be challenging for some people. We are actually working on a percent difference recommendation. We've really been struggling with this. We want to know, is 20% a good cutoff? Is 10% a good cutoff? We have not come up with a number. We were really hoping, we've done 500 patients now like this, trying to come up with a number, but our statistical values did not stay. We could not get a good p-value in what we were looking at. So our goal simply is to be absolutely as accurate as we can. I've managed my departments based on excellence. We compare all of our PET CTs to surgical pathology. We compare our cardiac PET CTs to cath rates. As technologists, this is one of the things that my staff did in my facilities. They needed, they wanted more responsibilities, and they wanted more pay, and all of these things, and to figure out and to understand how our imaging, what it does. It's the same reason why my technologists also follow these patients to surgery, so they can see what the surgeon sees, and that allows them to be better technologists or specialists, as I understand you guys want to be called specialists. I agree with you. Specialist is a much better word. It's to see if that nodule can be a metastatic deposit instead of a primary cancer, to provide information that may give our surgeons pause when we need to. We don't want that 82-year-old grandfather to get a biopsy that has COPD and all of these risk factors when they could possibly be watched and observed for another year. It's the medical is do no harm. When we can do no harm and give good quality of life, that's what we want to do. Our goal in this is to grow wisdom. We have knowledge, but we need to understand wisdom and how to utilize these systems. Pause. To biopsy a lung mass that has no elevation SUV instead of removing a lobe. We would come in, our surgeons were so caring of their patients, they wanted to be so aggressive, they would just come out and remove lobes of lungs because they had an abnormality. And then they would find, oh my goodness, that was a pneumonia. Well, you just put that patient through a horrific surgery because of a pneumonia, where you could have given them antibiotics, and that we must avoid. We've incorporated a Super D biopsy technique that allows 3D imaging into the single pulmonary nodule plan. And you guys don't have to worry about this because you already do this. But the vast majority of people in the United States aren't up to what you guys are doing for PET scanning. I have to tell people they need to include the top of the head. They need to get down to the knees and not try and cut off mid-thigh. You have to be conservative in the imaging. Adding imaging to the top of the head adds a little extra time, and it's negligible change of dose to the patient. You don't add any more FDG, but you do add a lot of CT dose. You do have to be mindful of the eyes. A lot of physicians in the U.S. are very concerned with exposing the eyes to CT dose. But it's just a matter of you have to pick your poison in what we're doing here. We must be thorough and accurate to make this change part of clinical routine practice. Because I can tell you that patient I showed you a moment ago, this was on the top of the head. Well, I'll show you some of these pictures. I apologize, it's a little rudimentary, but these are our hospital-based systems. Well, when we biopsy that scalp nodule, that was also cancer. And I can tell you the vast majority of U.S. facilities would have completely missed that cancer. You guys wouldn't have. You include the top of the head. This is very important in maintaining these good practices. So this allowed for early excision in that patient and good options. It led to a surgical intervention which allowed for a curative intent procedure, and that's the key. Typically lung cancer, that's stage 4 lung cancer right there, even though that's a really small tumor. It was both invasive squamous cell cancers. That's a dramatic change. A stage 4 lung cancer patient typically lives less than a year. That patient is on year 2 now. We keep following them with PET scans. So I wanted to touch base on head and neck cancer in my facility. PET CT is particularly helpful in this cancer. FDG is not the best tracer in head and neck cancer, but as far as we go right now, typically that is the best we have. Often lymph nodes are not pathologically enlarged by CT or MRI. Pathology in head and neck cancer or cancer of CT typically is larger than 2 centimeters or larger than a millimeter, so larger than a centimeter, excuse me. It's a helpful tool to perform high resolution exam through the area of interest. And what I'm talking about here is if they have a tonsil cancer, we do a second scan after the whole body to do just the head and neck area. Now, we take the CT down dramatically. We go down to 1.25 millimeter slice cuts for one bed position and a 9-minute PET acquisition. Now, I can tell you this does increase radiation dose. The reason why we do not have a hard time with increase in radiation dose in these patients, because every single one of them are going to get radiation therapy. We frankly don't particularly care what the PET scan is going to do. They're going to get 1,000 times more dose from the IMRT therapy to that field than what we're doing. Our job is to stage that patient the absolute best we can. Frankly, the radiation dose, it doesn't matter. We're not even in the same level as radiation therapy. We're not even the same significant figures. So we perform standard top of head to knees, and then perform high resolution to evaluate the head and neck. And I'll show you, this was the standard image that we did with your arms up. Here's the scan. You can kind of see something there, just a blush. I can show you the difference. When you do when you change it, it's better on here actually, but you can see this now becomes very obvious. It doesn't look like a blush of activity. It doesn't look like an infection process that's spread out. It's now very confined. The nodule is very easy to see on CT. This also allows us to put these into treatment planning systems. Frequently, we will do this on the patient bolted to the scanner for radiation therapy planning as this part, because our radiation therapists love this high resolution 9-minute scan. So comparing the standard imaging, the poor quality in the neck, poor resolution, you get it spread out. And the problem is you also get a beam hardening artifact by the arms up. The scanners don't do real well with gaps of air. You have the gap between the arm and the neck. It doesn't do real well in the algorithms. So you need better options. Well, in the head and neck image, you get high resolution, excellent quality, and it works well in treatment planning. But we do need better tracers, and that's kind of another topic. So the importance, this often changes the planned treatment for field of radiation therapy. We did a study on this, and it changed therapy planning 40% of the time. And I was really surprised by that number. And when I went back and did a research, also the U.S. did its large study of 30,000 patients and found that PET frequently changed treatment options more than 30% of the time. So then I felt a little better about this. But it's not perfect. It can reflect inflammation. Additional imaging is becoming more readily available, as FLT, fluorothiamidine, is an excellent tracer. It does not go to infection. This agent will be particularly helpful in identifying inflammation or infection, as the agent only goes to DNA overexpression. FLT is a great imaging agent when inflammation or infection is a concern. So the equipment, I thought I would add a little bit on this. There have been a couple of advances that really help in high volume facilities or facilities that just want excellent imaging quality for advanced imaging. New crystals. For example, the piece of equipment that we have has an extra row of detectors. So instead of 3 rows of detectors, you now have 4. Well, that typically makes the field of view go from about this to now this. So my standard PET-CT imaging time in my facility is 12 minutes. So you go from a field of view like this in the Philips system or GE to a field of view like this. So that means that you now have less time as the camera has to move, because when they did that, they also lowered the overlap. So in the standard cameras now, you have a 25 to 50% overlap, depending on what camera you're looking at. So you go from this with an overlap, and you only really go to here. You don't get the full bed down. You go from standard here, now there's no overlap. There's very little. So you can do 4 bed positions on a patient at 2 to 5 minutes a bed and do dramatically increase imaging time. The other interesting thing that's come out is you can vary bed times. So on the newest equipment on one of the vendors, you can take a patient and do 1 minute, 5 minutes, 5 minutes, 1 minute, 1 minute. So you can take where you don't have to move the patient around. You can know the head is small, 1 minute, or maybe he has head and neck cancer. I want to do 5 minutes here. The technologist or the physician working together can make these decisions and get the best image quality. Because as we know with technologists, yes, we would like to scan every patient for 40 minutes. But there is a problem. The longer you scan, the more the patient moves. Everybody knows this. There is always a fine line that you're walking between the excellent image quality and good, and patient movement and good output information. So the extra row detectors, this edition allows for very large field of view and decreased scan time. Decreased overlap with increased performance helps us to scan the entire body at once. This is especially helpful in imaging our infection patients that are on ventilators. My facility, we bring patients that are in our intensive care units down to the PET scanner to identify infections. We'll talk a little more about that tomorrow. We don't use indium-111 on patients that are septic because we want to know now. We want answers now on what's going on with that patient so we can address their antibiotic needs. The variable bedtime allows the newest equipment and allows us to be common sense and image longer when we need to. If they got a big gut, you image the gut longer. If they're shaped like a pear, you can image the pear. You can image the bottom longer. If they're larger up here, you can image longer up here. It just allows us to use common sense. So I can show you. This is a 12-minute image acquisition on a 180 kilogram patient. So there's no beam hardening. You can see truncation like that, as we learned about earlier. But this is a patient that came in from our unit that basically was, allows us quick image. You get an excellent image. And, as you move her head a little bit, but, on this side of the video, you don't worry about it. Because she's on morphine and all kinds of things. We're worried about the front of the body. There's no beam hardening. There's no, you get an excellent image quality all at once. You can see your catheters here. But it just allows us to do quick diagnostic, best patient care focused imaging. Functional imaging does that better than anybody. But we have not been set up to continue to do that. There are very few places that do this routinely. It's something that functional molecular imaging is moving that way. So projects, I can show you a few things that we're working on. Currently working on a protocol to perform 3-phase PET imaging. Sodium fluoride is something that we do routinely, and we have a lot of sick patients with diabetic feet, that MDP doesn't do a very good job. We're trying to build a protocol for 3-phase imaging. We do a lot of, list mode where you acquire all the data at once and you can reprocess it and do what you need with it. We're also working on delay imaging in liver tumors. Livers can be very challenging to image in patients because it's so variable, and they move around, as we talked about earlier. Fusing PET-CT with MRI and head and neck cancers. We would love to have a PET MRI, but do not have the $7 million that it requires to get one, and probably won't ever have that much money to get one. But there is good ways now that if you understand what's going on with MRI and you understand what's going on with PET, you can fuse them very successfully. You have to understand how that coil is being utilized in their MRI, or for the prostate, or for anything. We just have to understand and work with our other technologists in other fields to do the best that we can. And then we talked a little bit about today, diagnostic PET. Moving in and starting to do IV contrast when we need to, understanding when and who and what patients we need to do that. In the United States, this is a challenging area because this is when typically you have to have a physician within an arm reach in order to give diagnostic contrast. We have interesting laws when it comes to things like that. So in conclusion, FDG is a very effective and relatively cheap imaging material. Typically in the US, this is one of the cheapest materials we can get because you have such high volume. I hope that you can take some of my experience and begin to challenge commonly held ideas and to help expand image quality. Our patients never know the difference, but must continue to learn and continue our field. It's a very interesting, a lot of the Kuwaiti nuclear medicine is physician-driven. And I can tell you in the US, it's physician-driven as well. The physicians over the last decade, though, have found ways to empower the technologist. And I think, empowering the technologist to see and be able to communicate and have good dialogue is really important. Each one of these examples of what I showed you here came from a technologist, not from a physician. We started tracking head and neck cancers and realized that we did not do a very good job. And when we looked at our head and neck cancer PET scans and what the surgical output was, we didn't do a very good job. So then one of my technologists came up with a project to try and figure out ways to do it. Started looking at fellow hospitals, see what everybody else is doing in publications and things like that. In order to advance imaging in our own facilities, we have to do that ourselves. And that's what I had to say for this. Thank you. Any questions?
No question.
He's coming.
What did you mean by three-phase FDG?
For example, an MDP bone scan looking for a fracture, or you do first phase is flow in, if you do a pooling phase and then a delay. So the three-phase talks about flow in, and then the pooling phase, and then a delayed later.
So you kind of use a dynamic PET-CT. Is that something that?
That's what we're talking about. Yeah, being able to fuse a dynamic PET-CT with a CT to look for, especially in diabetic feet. Typically, these are very obese, very large patients. That MDP bone scanning is horrible. Indium 111 is horrible. You have bad image quality, bad image counts, and a lot of times these patients can't get into an MRI. At least in the U.S., this is a common problem in very obese patients. They're bad, poorly controlled diabetes, and their feet get these gangrenous infections that we try and figure out if it's into the bone, if it's become osteomyelitis, or if it's just soft tissue, infection. And that is a big problem. There's a big change in therapy management and outcomes if that infection gets into the bone. So we're trying to figure out how to use our sodium fluoride in those patients. But the sodium fluoride, you can see if it's there, but you don't get flow. All you get is the delayed, is it in the bone, which is very accurate for that. But we think that we want to figure out how to acquire it in a way that you can see it flow in and see it pool. And you can tell right from left. You're looking at both feet.
And you already have a protocol that, tells you how, as far as time per second,
there's
you already have something like that set up?
Or we're doing
the process to have something like that?
We're doing it now. We're testing it. We're basically, what we're doing is you do the scout scan, you do the CT scan, and then you hit the button to start the PET before you do the injection. And then since you acquire it in list mode, you could rebin it by the second, by the 2 second, by the 3 second. You can do it any way that you want, and figuring out. And then after you see what you want, that we're working on that protocol. I think right now it's going to be about 2 or 3 seconds, similar to like a renogram or something along those lines where you do 2 second. You can do really quick binning. The count rate in PET is basically uncollimated imaging, so you get millions of counts. We're very fortunate on PET scanning that nothing is blocked. There's no collimation like on an I-131 or an indium scan. So your counting statistics are excellent. Yes.
Just a curious question.
Sure.
For PET, now you are using, as you said, in your department you are using PET-CT modality. Okay. So you mentioned that who's using this modality is the technologist.
Mm-hmm.
But as we said,
I can hear it. Yeah.
Okay. So for the CT scanner, is it the same? The nuclear medicine technologist was using both, for the imaging, PET scanner and CT scanner,
Mm-hmm.
and for treating the parameters, is the technologist, the nuclear medicine technologist, is the one who's dealing with the CT scanner. Are they allowed to change the parameters of the CT scanner as well?
Don't touch it. We're just like you. We set up based on whatever the vendor's protocols are, and we don't touch it. Because we don't have to mess with the CT. Now if we do based on the head and neck, our physician has established a protocol that he or she had wanted, and we all got them to agree upon it, and then we changed it based on the physicians. When that's kind of going forward, we basically try and learn from anything that we have, and then we're allowed to set a protocol based on a patient, and then the technologist is then empowered to follow that going forward. That's one of the things that we're allowed to do, which is significantly different than here. But if it's just the same, if you're doing FDG over and over, we would never touch the CT, just like here. We're not CT technologists, we're nuclear medicine technologists. So that part is very similar to hear.
So just dealing with the CT scanner, I mean, they are using the CT scanner, but they are dealing with it as like a push button operator.
Right. If we do IV contrast, we bring one of our CT technologists over to help us. We just don't feel comfortable. I don't want to give IV contrast on a diabetic and put them into renal failure. There's just too much that it's not ingrained in me to ask, that I can't tell my staff, you need to do that. That's yes.
Why you are so generous with the injected dose?
I am trying to change that.
15 mercury, maybe 10 years, 15 years ago, or 20 years ago, we used to use 15 mercury. We thought that as you increase the dose, you're going to get a nice image.
Right.
But with that, you will reach to a certain level where you will increase random and scatter.
Right.
So we decided to go just below 10.
Right. And I hope to get there. My nuclear medicine physicians are the ones that force me to keep it at 15. That's not a choice. I have to do what they say.
Is it because you're dedicated to PET system? Because maybe before, if you have old system with a PET standard or specification of old crystals, maybe you would have lower sensitivity. But imagine sometime with our dedicated PET, we use a patient with large BMI, like above 35, we inject like around 7 millicurie and beautiful image quality with the 3 minutes per bed, whole body, and that's it, 20 minutes, you're finished.
No, I completely agree with you. It's just a physician-directed thing. They choose what the dose is, and even though I tell them we need to lower the dose, it's the same.
Because always I back up the European because they are a bit particular about the dose.
Yes.
So why not? The theme is to increase the time per bed, time of acquisition, as an alternative of increasing or injecting patient, especially with CT coming in the scene, and you don't want to have added up radiation dose.
No, I completely agree with you. Yeah, this should always be the way. You should put the patient first, lower dose as much as you can. I completely agree. It's the problem with politics and throughput in the United States is similar to physicians injecting here. We have our own nuances that our physicians are dose heavy. But I will tell you, a BMI 35 patient in the United States would be normal. We're BMI 50, 60.
We have, you know that Kuwait is the second in the whole world
after the US. Yeah.
In obesity, but we are cutting down, and I think we're increasing time per bed, a number of beds as an alternative.
It's a good alternative, yes. And I would like to do it myself. I've tried, and same with nuclear cardiology. Yes.
Well, I will have about hundreds of questions. It's really sometimes completely different approach, and really to talk, a lot of things to discuss, a lot of inputs, and really enjoy the discussion. Just just an experience because we performed. We have actually performed on weekly basis PET-CT also with the diagnostic CT with intravenous contrast, and we also did it with some different protocols, both for stomach cancer and esophagus cancer and some other form lymphomas. And we did it, and we also have the opportunity to change CT imaging to adapt because we are also radiographers, so we can do it. Just a question, are you planning for the future to also improve in this direction, maybe with the joint work with the radiographers on having also diagnostic CT, and you are also planning for technology companies to be increased, including this one, or not?
We are. I'm getting all of my technologists to education in CT. We are doing PET certification first. That's our plan currently. I have some technologists that started in CT and learned to go to nuclear medicine. About half my technologists are bachelor's degrees. The other half are CT technologists that did the training and education to become nuclear medicine. So we rely on their knowledge and moving them in when we need them. We currently only really do diagnostic PET CT with IV contrast when we're doing head and neck or treatment planning or stomach cancers, esophagus, things that we really feel like we need the IV contrast. It doesn't happen a whole lot for us yet. That's the best. But I do think that we're going to have to move that way. As much as we're doing SPECT CT, as much as we're doing PET CT, I'm worried about when it gets to be PET MRI. We don't have any business touching an MRI. So I don't know, as these modalities continue to advance, it just, we have to keep changing. And it's hard. It's hard to take a technologist that's been doing it for 25 or 30 years and get them CT because they don't want to touch it. They don't want anything to do with it. And I can't blame them. So it's.
I think it's as a member of the educator community of Society of Nuclear
Medicine Technologists are, I think it's a dilemma that people are discussing this. So it's like individual state process going through, like educating their technologies, doing their own CT certification courses. So everyone is trying hard to catch up with this multimodality.
Yeah. Well, my worry is very simple. Technologists can learn very easy how to run a CT scanner. It's not hard. My worry and concern is we have to have a focus on what's best for the patient. I don't want a technologist doing one diagnostic CT scan a month, and then they have an unusual patient a year from now, and then they hurt them because you need to be doing something every day. You need to be doing nuclear medicine or you need to be doing CT. You can't cherry pick and pull this person over here and throw them over here and put them right into the day. That's how you hurt people. So I think it's a real problem. I have a great concern, and it adds a lot of dose. There's a lot of examples and lectures of PET that you take the CT away, especially in sodium fluoride and things like that. There's a lot of places and, very well-known facilities that eliminate it as a dose reduction because it's hard. And a lot of states in the I can tell you a lot of states in the USA are now requiring technologists to have dual certifications. There are 7 states in the U.S. that if you are going to work there as a nuclear medicine technologist, you are required to have CT and nuclear medicine education. And, I think that's the way we're going. I don't want to go back and learn CT. I've been doing this a long time. That would be hard for me to do, but I think it's the way of the world. Yeah. Anybody else? Draw? I want to do it.